November the 1st, 2022, join us at the Conference on Dermatology and Cosmetology in Qatar. Under the theme, Recent Advancement, Changing the Future of Dermatology and Skincare. This one-day conference will feature a wide range of topics that will discuss the latest developments and findings on dermatology, natural cosmetics market and skincare, and will include interactive sessions like panel discussions, presentations, workshops, and the opportunity to network with other dermatology specialists and practitioners across the globe. What are you waiting for? Join us on our exclusive all-in-one virtual platform and register now in our website.
Assalamu alaikum and good morning everyone. On behalf of Next Fairs, I welcome you all to the first virtual Qatar Dermatology and Cosmetology Conference under the theme of Recent Advancement, Changing the Future of Dermatology and Skincare. This event is organized by Next Fairs and ZMZ Event as the conference partner. It's a one-day conference that will start with a keynote presentation followed by 6 sessions focusing on innovations, trends in dermatology, cosmetology and skincare. Now, to start the conference, I would like to welcome our key speaker, Ms. Naveen Balki, CHRO and Director, Global Talent Leadership, BSG Advisory. Naveen is a seasoned global thought leader who receives industry and leadership awards. She inspires leaders to invest in their own and organizational growth. Engaging teams in change, she sparks loyalty and excitement and leads complex acquisitions. Educated at a top US university with multiple certifications, Naveen's 24 years of leadership span over different industries. Ms. Balki leads a dialogue on influence at the top levels of the field, from her global experience at JP Morgan Chase on Wall Street to Mubadala UAE, Exxon, Ingro to Agrium, Nutrien Canada to a hospital board of directors. Welcome, Ms. Naveen, and the platform is yours to present.
Thank you so much, Rochelle. Really appreciate the introduction, and I'm really looking forward to sharing some of our insights in the industry with the leaders who are joining today. So the focus for the next 20 minutes or so is going to be on leadership skills that are relevant to your field, relevant to the field of dermatology and cosmetology. So we'll dive straight into it. We're here today to discuss your approach to leadership in your field and how you influence. So to start out with, I'd like to ask you a question. What does Nelson Mandela, there's a poem called Invictus, and the CEO of a world-renowned hospital CEO, and you, what do the three of you have in common? Just think about that for a second. What do you have in common? I'm sure there are many things. Today we'll focus on 2 of them, innovation and influence, which also happen to be a key area of focus for today's event. So as Rochelle mentioned, we are drawing from experience both in your industry, in the field of medicine, as well as other industries. And just to keep in mind for the next 20 minutes or so that innovation and influence comes from mastering yourself. It comes from self-leadership. And once we're able to understand that really unleashes the power of how we run our care teams, how we run our clinics, the departments in our hospitals, and our teams. And this really puts a nice stamp on meaningful impact, both to the people under your care and your teams. So that's a little bit about me. And I just wanted to share that, this type of work, leadership in your profession, we've done for many organizations around the world, in the Middle East, in the US and Canada, and in the Far East as well. And this map will just show you those locations. So, in the time that you have today, not just the 20 minutes with me, but with the rest of the speakers and the rest of the sessions that you are participating in, we'll keep a focus on reflecting what you hear, reflect on that. How much of it is really relevant to you? Where can you apply it? Learning and then change. Is there something in your practice that you would like to update or change based on what you hear in the day to day? And this is a simple and compelling approach to get the most out of your valuable time. We know all of you are busy, so we just wanted to put that in there to make the most of your time. I also wanted to take a moment to know that, learning and growing takes some investment and it takes some courage. So thank you for being here to invest in your learning and growth. So we'll start out with taking a quick trip around the world to a few derma associations. Let's start off with the US. So the AAD, the American Academy of Dermatology, and remember that these 20 minutes are focused on leadership. So what are each of these associations in different countries of the world for dermatology? What are they saying about leadership? What are they saying about core values? So the AAD mentions being patient first, member centric, really engaging in lifelong learning, visionary leadership, professionalism, and making sure that the work is scientifically founded and that there is unity amongst the professionals in this field. So those are some of the core things that the AAD is focusing on. And notice here that they talk about influencing quite a bit, how to influence decision makers, how to be more innovative, and also how to influence the curriculum at medical schools. So this concept of influence and innovation that we're focusing on is relevant to your profession. And I'm just going to ask as you join if you could just mute your mic so that there's less disturbance. And of course, we can have questions or comments at the end as well. So that was the AAD, the American Association, and then the BAD, the BAD, the British Association of Dermatologists. So what do they say about leadership skills and core values? Again, there is a key focus on influence and innovation, and really a recognition that the values of an organization in your field are just as important as any of the objectives, any of your work streams, and any of your successes. There's a key focus on things like equality, diversity, inclusion, as well as the climate crisis and how the climate is affecting how we treat skin, hair, and nails. And then, of course, there's a key focus on dignity at work as well. So that was the US and Canada. And then in the UAE, there's the Emirates Dermatology Society. And once again, you'll see a focus here on leadership, on integrity, on ethics. What about in Canada? Once again, there's a focus on promoting, protecting, and advocating. Advocating is also influencing. How do we influence those in our profession, those who are under our care, and those who report to us as part of our care teams? And the CDA, the Canadian Dermatology Association, also has, a lot of focus on diversity and inclusion in your field and how we can educate ourselves to be part of the solution in derma. And how can we amplify the voice of our colleagues? Again, that's about influence and representation. So Dr. John does a lot of work in leadership in dermatology. So you'll see that I've leveraged quite a bit of his research as well. So when we take on a leadership role in professional organizations, this leadership role should make us a better communicator and a more effective provider. And it's more than that, because being a leader makes the entire profession itself a little bit better. Also, the GMC, the General Medical Council in the UK, defines management or leadership in healthcare as getting things done well through and with people. And that creates an environment in which people can perform as individuals and also to cooperate, collaborate towards achieving the goals of the clinic, of the hospital, and of the clients, and also to removing obstacles. And then it identifies 6 or 7 key areas practitioners should focus on. Number 1, selflessness, integrity, objectivity, being accountable, remaining open, honest, and demonstrating our leadership. And so these 7 principles of effective leadership, effective management have been outlined by the GMC as well. And, several leaders in this field say that when we are more aware of what's going on in our field and why, we are better able to assist and mobilize others when issues do arise. For example, if there's changes in the law, in legislation, or if there's changes in reimbursement policies that might impact how and what our clients choose to do with us. And when we step into these leadership roles in our area of practice, we absolutely gain a different perspective. It's a broader, more strategic view, and it becomes more apparent. And from this perspective, then having a leadership role in our field, we're able to then have a really good bird's eye view of what are the options, what are the challenges, and then what are the solutions and actions that we can take in our leadership role. So when we kicked off a few minutes ago, we talked about influence and innovation. So we'll focus on influence today. We don't have too much time together. So I want to leave you with 3 ways to influence. And none of this is rocket science. It's just good reminders that in the day-to-day, sometimes, chaotic schedules, we may not be focusing on them as much. So the 3 ways to influence. Number 1, appealing to logic. Tap into the rational and the intellectual positions that your client or your patient might have, and that your teams might have, that your colleagues in your practice might have. So appeal to their logic, the budget, the industry, medical innovation, appeal to their logic. The second way to influence those around you is the emotional appeal. And this way, you're connecting your message and your goal to those on your care team, to the clients, to your colleagues, to their individual goals and values. And finally, the third way is cooperative appeals. We know in our field, collaboration is key, consultation is key, being allied with the right practitioners and the right technology is key. So appealing to that spirit of cooperation and collaboration. So these are 3 ways to influence. And in any one situation, you may only need to tap into 1 or 2 of them, or perhaps into all 3 of them. And diving deeper a little bit into this, 4 key ways. 1, understand the intelligence of your organization. Your organization could be a small practicing team. Your organization could be a mega hospital or multiple institutes that you're affiliated with. So it's to understand what are the formal and informal structures of where I work. How are decisions made? How is budget allocated? How are clients dealt with? What is the formal, the visible, and the less visible structure of my organization? Second is team promotion. So one way to influence others is also to make sure that we are recognizing the work that others are doing around us. This is also part of EQ, giving credit where it belongs. The third part, and we'll talk about this later on as well, is trust building. So maintaining trust to guide people through risk and change. So this element of how much do my patients and my clients trust me? How much does my team and my colleagues trust me? And then, of course, we all have networks, whether we recognize it or not, we all have networks. So how can we recognize and cultivate the power of our network to create positive change in our field? So you'll see in materials that you read, perhaps, that there's quite a bit of emphasis in the last few years and more recently on the politically astute leader. So what does this entail? can one of the organizers please let in the folks who are in the meeting in the waiting room? Thank you. So if you look at these three circles, on the bottom left is IQ. We're all familiar with IQ, intelligence quotient. Then there's EQ, emotional intelligence, and then there's PQ, political astuteness, political quotient. So when you combine the left two circles, this is what gives us some indication of how we think strategically. When we combine the right two circles, the emotional and the political intelligence, that leads to us being savvy, how we are penetrating the market, how we understand the needs of those who are coming before us. Then when we integrate the bottom two, that's where what people would typically call, oh, it's a smart doctor, it's a smart practitioner. And finally, in the middle of all of this is what we would call astute. When we have a good balance between the IQ, EQ, and the PQ, that's really an astute practitioner. And there are 6 things that you can keep in mind to really lead you to that sweet spot in the middle of, intelligence. It's really understanding perception, and we'll talk about that in a minute. What is your leadership style? How do you network? Do you really think before you speak? And how do you manage up and 360 around you and the team below you? And are your patients, are your teams able to see your sincerity? Are they able to feel it? When we talk about leadership, as you may have heard this example of how many times have you shown up at an airport? And right now with FIFA, the airports are crazy. But have you come to the airport and be like, oh, let me look at this departure board and decide where I want to go? No plans, no luggage, no ticket. I'm going to show up at the airport and decide where I want to fly to. Maybe a few adventurous souls, but most doctors don't have the luxury and the time to be that spontaneous and that off the cuff. So compare that scenario to the scenario of a guide who shows the path, a guide who can help the care team, your colleagues around you, to come closer, to trek closer to the vision that you have, the vision that your practice has. And to enable that vision, expectation management is very, very important. Expectation management with those who are under your care as well as in your team. And Shakespeare said that, expectation is not managed well. That is the root of all heartache. So this can be done formally or informally. Feel free to take pictures of anything that might be relevant to you. So when you look at expectations, you can think of a simple 4-grid tool. What is your role? What is your team's role? What is your view? And what is your team's view? And then these 4 questions can really help you answer, okay, what am I supposed to do? What is my team supposed to do to support me? And how are they going to be held accountable? So our clients, our patients, they hold us accountable to certain standards. They have certain measurements and metrics. Some of them are stated and some of them are unstated. The more that we can get clarity on that, the higher the probability of success. And as we're communicating, think of this pie chart. This is another tool I wanted to leave with you. Very important because many of our clients and patients have evolved understanding of the procedures they're going through, and many of them don't. So our body language actually plays a huge part in how we communicate. The tone of our voice has a huge part. Most people, if I'd ask you to guess, most people do not guess that words are the smallest part of this pie chart, only 7%. So how we communicate, how we understand each other, a big part of that is body language. A big part of that is the tonality of our voice. And something else for you to keep in mind is the Johari's window. So you can, again, anything that feels relevant to you, feel free to take a picture of it. So this is really a model to help us understand how self-aware we are. So if something is known to us and others, that's the top left. It's open. Everybody knows about it. If others see this in you, but you don't see it in yourself, that's what we call a blind spot. And the bottom 2 areas are hidden, either to others or to ourselves. So If you think about growing, when there are team members that are around us who are open and we have that open communication with them, this is what helps to shrink this top right area, the blind spots. And if you ask for feedback, you see this arrow moving to the right, asking for feedback really helps to open up. And then insight again helps to move things into the top left, things that I know and things that the others around me, are aware of as well. So with open feedback, with shared insights, we reduce the blind spots that we are dealing with. So when we're thinking about leadership, when we're thinking about leading our teams and our clients into different procedures, the key ingredients of success and failure rest with us and our team. We had talked about perception. So, perception is how we understand the world around us. And what I don't understand in myself, I can't understand in others. And so you may have seen this is an old image, but it still resonates with a lot of leaders. Like how we see each other, how we see ourselves may not be how we see the other. So, for example, how do you view, and you don't have to answer, but just to think within yourself, how do you view your team? How do you view your clients and patients? Because that leaks into the interactions you have with them. So, how do you think of them versus what do they think about themselves? And if you get an understanding of this, this really helps for effective communication. So, what do you see in this picture very quickly? Perception is different. You know, some of you may see duck, some of you may see a rabbit, some people see both. Is it wrong? Is it right? It's different. What do you see here? You can mention in the chat box. Most people would say the face of a clown. But if you look at it slightly differently, on its head, if you turn it around, what do you see? Probably a full circus. The horses, somebody with the hoops, the dog performing some tricks. So the face of a clown on its head turns into a whole circus. So perception is persistent. If somebody was nasty to you in your career, in your school, it's unlikely that you will name your child by that name. So when we think about how others perceive us, trust is a huge element of that. And what trust is built on is a shared vision. And then DWY is YWD. What does that mean? Any guesses? Do what you say you will do. Give everyone an opportunity to contribute. Do what you say you will do. So this is a key element of trust. And we are what we do, not what we say we'll do. At the end of the day, this is how people measure us. And so if you need to influence quickly, nothing is as fast as the speed of trust. So if our teams, our clients, our patients trust us, then that helps for much faster decision making and better decisions. And if we don't have trust, we're actually paying a trust tax. And if we do have trust, speed increases and the cost decreases, the cost of running our practices. There are 13 behaviors of high trust leaders. This is work that is done by Stephen Covey and Stephen M.R. Covey. It's readily available, but pick one or two that you feel are most relevant to you. You know, how do you eat an elephant? One bite at a time. So we don't have to pick all 13, but pick one or two that really resonate with you and you feel are really required in your business. So talk straight, practice accountability with ourselves and with our team members. People actually perform better when they're held accountable. And then keeping commitments, not breaking confidences, and using our voice. As a practitioner, as a leader in your field, we all have a voice. And this element was mentioned in the core values I shared with you in the beginning. that were mentioned in the American Association of Dermatology and in the BAD, British Association of Dermatology. So we can end on that note. We are on a tight schedule, but really leveraging our voice, having it heard their leaders is what prompts discussion, was what prompts better care. So thank you very much for your time. I really appreciate your time. And if you have any questions, you can either post them here or post them on the conference platform. Thank you. Back to you, Rochelle.
Thank you, Ms. Naveen, for the Kickstart presentation on business leadership skills for global dermatology experts. It was a pleasure having you with us today. We are now starting our first session with the topic of dermatopathology. To take this forward, I would like to welcome our first speaker, Dr. Ahmed Amin, Specialist Dermatology and Genitourinary Medicine, NMC Specialty Hospital. Dr. Ahmed is an international fellow of the American Academy of Dermatology and European Academy of Dermatology and Venereology. He's also a member of many dermatological societies such as the International Dermoscopy, Emirates Dermatology, Emirates Medical Association, and Saudi Society of Dermatology and Dermatologic Surgery. He participated in many clinical trials as a principal investigator in psoriasis, atopic dermatitis, and acne, with many publications, posters, and abstracts in international journals and conferences. Welcome, Dr. Ahmed Amin, and the platform is yours to present.
Thank you very much for the kind introduction. It's a pleasure to be with all of you today. So today we'll talk about what's new in dermatology. So my main objective is to stay updated because we are practicing in a very interesting field, and every now and then there is something coming new to our field. So we have to be the best version of ourselves with a daily updates what's going on in the field of dermatology. So in my presentation, I will represent the most interesting articles that has been published maybe in the last year, basically in the European Academy Journal and the American Academy Journal and the British Journal of Dermatology. So we'll go briefly for this interesting publication. So starting with what's just recently published from the European guidelines in the atopic dermatitis treatment. In the area of atopic dermatitis, we have almost 5 new medications in 1.5 years. And this has never happened in any dermatological field in the last maybe 20 to 30 years. So now we have a stepped care plan for the other atopic dermatitis. And as we can see, as a first line systemic therapy in the severe patients, we have almost 4 or 5 medication. Baricitinib has been approved by the EMA, cyclosporin, dupilumab, tralokinumab, and ubadasitinib. So any of these medications, according to the updated European guidelines, you can use it as a first-line systemic therapy. For the last 5 years, we only have dupilumab and we have cyclosporin in some countries. But now we have, as per the EMA approval, we have 5 medications can be used as a first-line systemic therapy. And there is an update coming maybe for the aprocitenib because it also has been approved. So we have new medications, new innovations for the patient with atopic dermatitis that really we can help them. When it comes to the children, the adolescent, only dupilumab, ubadasitinib, and cyclosporin can be used in this age. Cyclosporin can be used from age of 16 as per the EMA license. Dupilumab can be used from age of 6 as per EMA license. Ubadasitinib can be used up to 12 years and above as per the EMA license. Maybe the FDA have a different opinion. FDA is licensing dupilumab maybe from 6 months, ubadasitinib maybe from the same age. So we again have a big hope for the patients. So moderate to severe atopic dermatitis patients, we have lots of new medication that we can use as per the recent labels that has been published in the European Journal of Dermatology. Going to the American Journal Association between alopecia areata and retinal disease, there is a nationwide population-based cohort study. They are testing and investigating if there is any association with atopic dermatitis and retinal disease from an autoimmune background. And they highlighted that alopecia areata is an autoimmune disease that not only affect the hair follicle, but may have some affection for the eye system, retina, optic lens, and also the cardiovascular system. And they are advising us that patient of alopecia areata, they are at high risk for developing retinal detachment and retinal artery occlusion compared with the other people which is not having alopecia areata. And we as a dermatologist should be aware of that, should be aware of the possible comorbidity, and maybe we need to take an action in a certain time with referring the patient to the other specialty to check these comorbidities. 1 year safety and efficacy of tapinarof cream for the treatment of lake psoriasis. What tapinarof cream is? It's an aryl hydrocarbon receptor modulating agent. What does it mean? What it did in psoriasis? We have a very nice result. And this can represent a novel non-steroidal topical therapy that addresses limitation of the current therapy, which is the side effect of the steroid. What we have as a result, we have a very good result in the mild to moderate patients, as we can see the photos in the baseline and after 12 weeks, and the result is maintained up to maybe week 48, so up to 1 year, the patient is maintaining a very good result. So we maybe have a new innovation in topical treatment of psoriasis, which is not only steroid, not only vitamin D analogs, and maybe something else will become very soon for these patients. Still in the American Journal, long-term mature safety and efficacy of tralokinumab in adult moderate to severe atopic dermatitis. So tralokinumab, as we know, is an IL-13 blocker licensed, as we said, in the European guidelines from age of 12 and from age of 18, and now recently 2 weeks back or maybe 10 days back, it took approval for the adolescent patient from age of 12 and above. So what we have here as a safety and efficacy for 2 years data, we have almost catching 80% improvement in the EASI-75 with a different analytic methods of the statistics. So even as observed, last observation carried forward, non-responder imitation, whatever the statistical analysis that you are using, we still have from maybe 80 to 85% of the patients, they still catching the EASI-75. So medication with a very good safety profile as a selective IL-13 blocker with a good data for long term, definitely it was a very interesting unmet need in current treatment option of atopic dermatitis. So again, that's a very interesting point. So they highlight that this result supported the long-term continuous use of tralokinumab in adult patients with moderate to severe atopic dermatitis. And as I mentioned, the good news, it has been approved for the adolescent 10 days back in the European Medical Agency. It's a comparison between a treatment option, the adherence persistent for the patient who's taking ixekizumab and secukinumab in the psoriasis patient. So as we know, secukinumab is almost 6-7 years old now as an IL-17 blocker for the psoriasis, doing very well for the patient. Ixekizumab maybe from 2017, another IL-17 blocker. So they are comparing the treatment adherence, the persistent and the discontinuation rate. So what they mention is the probability of persistence of the treatment was little more for the ixekizumab. The probability for discontinuation was little more for the secukinumab. The probability of switching was from secukinumab to ixekizumab. So we don't have a head-to-head trial versus both of them, so it's lacking. But this study examined the long-term real-world treatment pattern for these drugs, finding that compared to secukinumab user with the ixekizumab, they provide the data that maybe for the ixekizumab, the patient can still little more, and the shifting was reported more for secukinumab to ixekizumab. Difamilast, what difamilast is, it's a selective phosphodiesterase 4 inhibitors as a topical treatment for atopic dermatitis patient. You know that we have an oral phosphodiesterase 4 inhibitor, which is apremilast in treatment of psoriasis, but now it comes as a topical cream, a topical ointment in treatment of atopic dermatitis. So what's the result that we have? We have a very good result, improving in the EASI score within 4 weeks, come down about 50%. So we have a very interesting data from the phase 3 trial demonstrating that difamilast is a phosphodiesterase 4 inhibitor, is an effective, well-tolerated treatment option for atopic dermatitis, and may overcome the safety concern of the existing topical therapy, because as we know that PD4 inhibitor as a class is considered as a very safe class, either it is topical treatment or oral treatment. So atopic dermatitis innovations, I don't think that it will end in the near future. We will still have new molecules in this field. Patient-reported outcome in the JET compare aprocitenib, the 2 different doses versus placebo versus dupilumab. What's the result that we have here? We have that the 2 doses versus the placebo, even versus numerically improvement, better than the dupilumab in the patient with patient with moderate to severe atopic dermatitis. So that is a JAK1 selective inhibitor doing very well in the 200 milligram dose, even numerically better than the dupilumab in treatment of our patients. Again, atopic dermatitis, if there is any difference in the comorbidities between the smoker and non-smoker patients, what we have today, according to the German registry data, which is published in the European Academy Journal, that the patient of atopic dermatitis who smoke have a higher disease burden with a different distribution pattern of the lesion in adult atopic dermatitis if they compare it with the non-smoker patient. So the association of comorbidities of atopic dermatitis sometimes is related to lifestyle factors like smoking and alcohol intake. Rosacea and upper gastrointestinal disorder. We're still learning lots of theories and lots of school about rosacea because we don't know what to do in such patients because we still don't 100% identify the cause. Here we have lots of gastrointestinal tract manifestation can associate with the rosacea patients, so we need to take care of that maybe we need to refer the patient. Low dose oral minoxidil increase the hair density. Oral tablet is doing very well in some patients, as we can see here. In 24 weeks we have a significant improvement with the oral dose minoxidil. Atopic dermatitis phenotypes and asthma, we know that the patient who have a persistent moderate to severe disease, they are prone for developing asthma, so the concept of atopic march will never end. Continuous finding the COVID-19 vaccination, even after 2 to 3 years, we still have a case report. We still have lots of side effects has been reported recently, earlier, late, for the vaccination. All of these have a vasculitic background, even with the long-term use of the vaccine. Moving forward for the topical finasteride for the androgenic alopecia, we have a very interesting data that topical finasteride without any systemic absorption, as we can see in the right curve with the flat curve of the DHT level before the treatment and after, no systemic absorption, but as per the dermoscopic picture on the left side, we can see a significant hair growth after 24 weeks. So topical finasteride may be a very interesting alternative option for the minoxidil. Again, COVID vaccination and other diseases. This is a psoriasis flare. Again, COVID vaccination with the lichen planus case report. Very interesting data. We're still learning from COVID lots and lots. Intralesional candida antigen immunotherapy in the treatment of anogenital wart. We use the MMR, the BBD, the BCG for the viral warts, the plantar warts. It did well. Unfortunately, according to this study in the anogenital wart, the candida antigen is not doing that much great. Only 3% of the cases has been resolved. Some improvement reported in 60%, but we have 35% without any significant improvement. Atopic dermatitis patient who is not responding very well for the dupilumab, especially the facial case, when they shift to upadacitinib, we have a very good result. So face atopic dermatitis, which is resistant with the dupilumab, according to this publication, upadacitinib can help with this patient a lot. Association with atopic dermatitis, eye hypertension. Again, the concept of atopic disease, the concept of comorbidities. According to the British Journal publication, they highlighted that the patient with moderate to severe atopic dermatitis, they have a higher risk of hypertension compared with the other patients. They identified diagnostic criteria for the patient who have a psoriasis, and they put more than 16 points that you can diagnose psoriasis in this age population. Efficacy and safety of apremilast. For the first time, we are seeing systemic treatment for psoriasis for the mild patient. Why we use apremilast in this age, in this category for the patient? Because of the safety profile. So we have a very good data for apremilast in mild patients, and this is maybe another area we'll see in the future that we may use it as early as possible to control the disease progression and improve the quality of life of the patient. So we have the passive 75 response, or about 30 to 35% of the patients within the first 16 weeks. Risk of lymphohematologic malignancies in the patient with a chronic psoriasis. We investigate in this trial the psoriasis patient and the incidence of these hematologic malignancies, and they say that there is an increased risk of this kind of malignancies. So sometimes we need to be aware, and the interesting point here, it is the risk is higher 6 times more than the control people, but here it is regardless of the treatment option. So it's not a matter of biologic or systemic conventional therapy. So psoriasis as a disease has a causal link with these kind of malignancies. Spinos had 0.9%. There is a new treatment option for the scabies with a single application. Maybe it will come to the market very soon, has been approved by the FDA already. A phase 3 trial, which is evaluating the safety of secukinumab in pediatric population, already has been approved by the EMA and FDA with a very interesting high curve, even better than the adults, and very good safety profile as well. What about chronic urticaria in Germany? They are seeing the incidence of comorbidities with this, and the interesting point that all these comorbidities, the hypertension, the obesity, the asthma, it has been reported even more than psoriasis and atopic dermatitis. So the bad phase of urticaria sometimes is very significant, more than even other autoimmune diseases when it comes to the skin manifestation. Application of an emollient to the newborn skin from the birth for the prevention of atopic dermatitis, it did very well. So if you have a family history, the neonate, this has happened in Thailand, neonates, you can apply a moisturizer cream from day 0. Sublingual minoxidil is another route, did very well in some patients with a significant improvement within about 16 to 24 weeks in this phase 1B trial. Risk factor for the scabies, they are highlighting that the scabitic patient with a limited mobility and topical steroid use before the diagnosis of scabies, making the case difficult. Another molecule, difamilast, selective phosphodiesterase inhibitor, comes into the atopic dermatitis, as we mentioned earlier in other journal. Again, the Canadian journal is highlighting this with a very good data. Psoriasis and colorectal cancer, it is again interesting point. They highlighted that psoriasis patients have an increase, so gastroenterologists may be enrolled in these cases. Association between vitiligo and hearing loss, again interesting point. According to this publication, dermatologists treating patient with a vitiligo, they may be enrolled for ENT consultation. Risk of skin disorder with a celiac disease, a patient with celiac disease, they have lots of associations with dermatological manifestation. Hidradenitis suppurativa and atopic dermatitis, we saw many publications treating dupilumab with both diseases. So there is a causal link between HS and atopic dermatitis. Tonsillectomy and psoriasis, there is some risk of psoriasis in the tonsillectomy group decreased. So some of the patients, especially for the gutted psoriasis, tonsillectomy may help in the course of the disease. 3 years efficacy of certolizumab, which is TNF blocker in the psoriasis. We have a good data, about 75% improving in the PASI score, PASI 90 responders, and they are maintaining more year by year. The adalimumab patients in HS, we have more data now for 2 to 3 years, and they are a significant reduction in all these parameters, the abscesses, the inflammatory nodule, the draining fistula. So again, still we have hope for this patient. Is IL-23 blockers working in the palmoplantar psoriasis and palmoplantar pustulosis? There is a hope according to this data that we have now. Ixekizumab in the nail psoriasis, they have a very good data as the skin, as well as this publication in the European journal. Apremilast case report will never end. This is in the recurrent erythema nodosum leprosum with a very good clearance level for the apremilast. Long-term efficacy of risankizumab, 5 years data for the limitless, very flat curve. 90% of the patient, they have PASI 90, 60% of the patient, they have PASI 100 for 5 years. Not only that, guselkumab, the other IL-23 blocker from the Voyage 1 and 2, again, the 5 years data have 85 to 86% of the patient, they are achieving the PASI 90, and the PASI 100 achieved in more than 50% of the patient. For the patient of HS, if you give the intravenous clindamycin before the oral clindamycin, it did very well in the patients. So we may give the intravenous clindamycin for 5 to 6 days before the oral, have a very good result. Interesting publication for the atopic chondrodermatitis nodularis and the helix of the ears because of the ear headphones. So that is again a causal link. We may need to take care of that. Anti-psoriatic drugs will work better in the woman than men. Women follow the rules. Women have less obesity. Women, they are listening to our instruction more than men. So maybe you have a different dosage in the future. With that, I'd like to thank you very much for your attention. We can move to the question if any of you have any question or any comment for the publications.
Thank you, Dr. Amin. It was a pleasure having you with us today. I would like to mention that we have, as of now, more than 500 global attendees watching us. Now we are moving to our next speaker, Dr. Ali Youssef, Arab Board of Health Specialization. Dr. Ali graduated from the University of Khartoum, Faculty of Medicine. He started his career in clinical dermatology and venereology, Arab Board of Health Specialization, and currently doing his residency training in Khartoum, Sudan. Welcome, Dr. Ali Youssef, and the platform is yours to present.
Hello, everyone. Good morning. Okay, hello. My name is Dr. Ali, and I am a third-year registrar of clinical dermatology. During the last year of my residency, I keep notice the strong relationship between the psychiatry and dermatology. So I decided to take this notice from the observation to action form. Therefore, I'm happy to introduce you to my presentation today, which will be about the effectiveness of psychosocial support in the management of complicated case of pemphigus vulgaris. We all know that pemphigus vulgaris is considered as a chronic autoimmune disease clinically manifested by the presence of bully and painful erosion of the skin and mucous membrane. The disease is characterized by poor prognosis in the absence of medical treatment, and duration of severity of pemphigus vulgaris depends on the interaction between the predisposing and the inducing factor. To the best of our knowledge, severity of pemphigus vulgaris appears to be linked to the mental health of the patient. Therefore, I will try to focus on the psychiatric and psychosocial side of pemphigus vulgaris instead of clinical form. Therefore, I will introduce you to my patient today, 65-year-old female housewife from Hamrat al-Sheikh, Eastern Sudan. She came to our hospital complaining of widespread asymptomatic blisters and wounds on both legs, feet, arms, on forearm, abdomen, and back, generalized almost all over her body for 2 weeks, and on her mouth and lips for 2 months. Please take a good look on this picture. I will show you this picture was taken almost on the 6th of June 2022, 4 months ago. Please take a good look on this picture. This was the patient look when we admit her to the ward of the hospital. When we admit the patient, we take the history. The patient was already diagnosed with pemphigus vulgaris 2 weeks ago, 2 months ago before the admission. She was think that this is not a medical condition. She thinks that she thought this is something like a black magic or something. Therefore, they started the treatment, but she stopped the treatment. So it came to us with a flare-up of pemphigus vulgaris. It's a very strong and very aggressive than the disease of pemphigus vulgaris itself. There was no associating symptoms, no aggravating or relating factor. The blisters started on her legs 2 days and involved the upper limb scarred, then it involved the lower limb. Blister started small in size, then enlarged and ruptured in 2 days. Discharge of serous fluid leaving erosion or in space. So therefore, we take the history of previous attack. She received oral steroid tabs for 5 days, then 2 tabs for 5 days, then 1 tab. She also received topical treatment as well. Patient condition improved, but when she stopped the oral medications, the blisters start to appear again. Not all lesion didn't improve at all. Her systemic review, drug history, family history, social history was unremarkable. Her past history was unremarkable besides the previous attack of pemphigus vulgaris. On the dermatological examination, there are multiple skin lesions in form of vesicles and bulla and erosion in both lower limb and abdomen and her chest and back. Upper limb including axilla, neck, and lower lip and scalp. As I mentioned before, all over the body. She can't wear clothes when she at hospital. The vesicles and bulla was bilateral, asymmetrical, contained serous fluid on normal skin base. there are 10s with positive Nikolsky sign. There were no specific pattern of distribution. On the scalp, there are erosion, oozing cirrus, and no hair loss. On mucosal examination, there is erosion on lower lip with hemorrhagic crust erosion on uvula. The diagnosis, as I mentioned before, after clinical examination and the biopsy was taken, it was confirmed pemphigus vulgaris. So when we came to the management plan, we start the classic management plan to any dermatological case. We start with IV steroids, antibiotics, and full dressing of the wound. Failure of general investigation were taken to monitor the patient condition. But unlucky, after 1 week of the admission, there was no improvement and she looked severely ill. Reviewing her past history, including non-compliance of oral steroid and mental state assessment, revealed she was very anxious from the disease, believing that she will never survive and get back to her skin as she was before. Therefore, I asked my consultant if we can go to psychosocial administration office in the hospital. We found that psychological evaluation and counseling for the patient were added to her management plan, along with other medication. On the regular follow-up 2 weeks later, she was remarkably improving, showing a very good response to the newly adjusted plan. She thought she could be in good condition again. Therefore, she receiving very well to the treatment, to the drugs. You know, just take you a bit. I gave you a picture of patient with admission 6 weeks later, and almost 1 month after we start the psychosocial support. Look at the patient now. She was discharged happily and full and clear from the disease after 1 month when we start psychosocial support. Therefore, in conclusion, the psychosocial evaluation and counseling for patients with the dermatological disease should be considered as a management option along with medication, because the effect of the skin disease could go beyond that. Moreover, the positive outcome of psychosocial support should be highly valued in the management of dermatological disease. Thank you very much. This is my presentation. If anyone can ask a question or. Yes, thank you very much for listening to me. This is my presentation for you today. So if anyone has a question or something, I could go answer them. So there is a question here: what is the relationship between dermatology and psychiatry? I think there is a strong relationship between dermatology and psychiatry because of the effect of the dermatological skin condition or to the patient condition is strongly on the disease affects the face and behavior of the patient become very aggressively ill or something. When he gets the support, psychosocial support or psychiatric support, he starts to think he will go better, and that's why I think there is a strong relationship between dermatology and psychiatry. To the best of our knowledge, even a lot of manifestation of dermatological disease strongly increased by.
Thank you, Dr. Ali. It was a pleasure having you with us today. Now let us move toward the next speaker, Dr. Ibtisam Al-Fakir, Dermatology Department, Abdelmalik Al-Saadi University. Dr. Ibtisam is a dermatology resident at the University Hospital Center of Tangier, Morocco.
Thank you. Good morning, everyone. It's a great pleasure to be here today with you, and thank you for giving me this chance to be part of the speakers at Qatar Conference of Dermatology and Cosmetology. My presentation today is somewhat specialized about a pathology. It's about an observation of hypopigmented mycosis fungoids with a brief update. So let's begin by introducing our patient. 42 years old female teacher and native and a resident of Tetouan with no significant medical history. She presented at our department with dyschromia evolving in 3 years. The patient is Fitzpatrick skin type 4. The physical examination showed multiple hypochromic non-scaling macules on the trunk, periumbilical region, flanks, and arms with no loss of sensation, no lymphadenopathy, or any other associated symptoms. For dermoscopy, it showed white and pale area. Yes, with ill-defined borders, chrysalid patterns, creamy white and erythematous background, and finally, very fine white scales. For histopathology examination of skin biopsy showed a psoriasiform dermatitis with an infiltration of the upper dermis, epidermotropism along the basal layer, caesariform lymphocytes, pilotropism, and absence of melanic pigment in the basal layer under Fontana-Masson stain. Immunohistochemical profile objectified CD3 positive lymphocytes, intraepidermal CD8 positive T cells, atypical intraepidermal CD4 negative T cells, and with HMB45 labeled scattered basal melanocytes with some uninhabited intervals, and also A-cadherin who showed diffuse labeling along the basement membrane was preserved. Our final diagnosis was hypopigmented mycosis fungoides with no secondary sites objectified in the extension assessment. Beta-2 microglobulin and LDH were in the normal range and no Sézary cells were found. The patient was put on very high potency topical corticosteroids and she was a candidate for phototherapy. The patient was recently examined after 8 months on topical corticosteroids. We noticed an interesting improvement in skin lesion. Now, in matter of discussion, hypopigmented mycosis fungoides was described for the first time by Ryan in 1973. It's a very rare and atypical variant of mycosis fungoides with predilection for younger population with dark skin tone and characterized with a slow evolution. Its prevalence and frequency are unknown. Sex ratio tends to be equal, with except in 2 case series where authors found a feminine predominance in the first series and a masculine predominance in the second one. The defining clinical features of hypopigmented mycosis fungoides are asymptomatic round or oval-shaped hypopigmented to achromic macules or patches with different degree of scaling. The majority of patients experience a delay in their diagnosis, on average years after the first dermatological signs. This is due to similarity with differential diagnosis. In fact, hypopigmented mycosis fungoides could be easily misdiagnosed as vitiligo, leprosy, or post-inflammatory hypopigmentation. Dermatologic features were rarely reported in the literature. However, a preliminary Chinese study in 2020 investigated the role of reflectance confocal microscopy in the differential diagnosis of hypopigmented mycosis fungoides and vitiligo. They found an excellent correlation between the finding of confocal microscopy and histology results. On the left image, we notice the significant reduction or absence of melanin, which is mentioned in a red circle in the basal cell layer during vitiligo. The image on the right shows the monomorphous weakly refractory oval to round cells, as you see in red arrows. On the basis of physical dark space were clearly elucidated in epidermis of the lesions by confocal microscopy, which indicates the portrait microabscess on histopathology. On histopathologic examination, the findings were focal parakeratosis, mortal spongiosis, upper epidermis lymphocytic infiltrate, and various amount of lymphocyte at all levels of the epidermis. Some authors report an intense epidermotropism and Pottry's macroabscesses, but they are less common. We can also find minimal psoriasiform epidermal hyperplasia, follicular tropism, and melanin incontinence in the papillary dermis. However, the histopathological examination may not be enough for the diagnosis, and immunohistochemical study is then necessary. It will show an epidemic of CD8 positive lymphocytes. The etiology and pathogenesis of mycosis fungoides are not fully understood. Several hypotheses have been advanced, including neoplastic cells cause melanocyte degeneration, and therefore abnormal melanogenesis, abnormalities or blockage of transfer of melanosome to keratinocytes, and the predominance of CD8 positive T lymphocytes, which is compatible with the hypothesis defending that if hypopigmentation results from the cytotoxicity of lymphocytes mediated suppression towards melanocytes. The hypopigmentation could be explained by the decreased CD117 expression in melanocytes. This decrease and its downstream events in melanocytes may be initiated by cytotoxic effects of specific CD8 positive neoplastic T lymphocytes, resulting in destabilization of CD117 and leading to dysfunction or loss of melanocytes. Another recent study correlated early onset and good prognosis of hypopigmented mycosis fungoides, which achieved anti-tumor immune response. Specifically, reduced level of certain factor such as beta FGF, CD117, tyrosinase, MART1, melan A, GP100, and MTF lead to disruption of melanocytes function. Thus, if hypopigmentation is a clinical marker of this anti-tumor immune response, and therefore a favorable prognostic indicator. Recently, an Egyptian team proved the involvement of a protein encoding genesis which is TOX, site selection associated high mobility group box, in the differential diagnosis between hypopigmented mycosis fungoides and vitiligo, which is with a high degree of specificity and sensitivity. Indeed, TOX seems to be expressed in cases of hypopigmented mycosis fungoides, regardless of the lesional immune profile. Regarding treatment, as most cases of hypopigmented mycosis fungoides are stage 1 therapies such as PUVA with oral psoralen, narrowband ultraviolet B therapy, topical carmustine, topical corticosteroids, and topical nitrogen mustard all have been successfully used. In this study, biopsies of repigmented lesion after nitrogen mustard treatment revealed numerous normal appearing melanosomes in the keratinocytes, suggesting that the nitrogen mustard mechanism, in addition to histologically clearing mycosis fungoid lesions, it can reverse the melanosome transfer defect and activate melanocytes. Ultraviolet treatment shows in several studies complete repigmentation in almost 1 to 2 months with success in more than 90%. An online survey of members of the International Society of Cutaneous Lymphoma found that for phototype 3 and above, survey participants preferred narrow band UVB over PUVA for stages 1A and 1B. Others suggest that PUVA works better than narrowband UVB for darker phototypes in the early stage. On the other hand, narrowband UVB treatment is to PUVA by several authors, given its low carcinogenic risk. And we conclude with this article suggesting that biopsies and immunohistochemical have confirmed that complete repigmentation is correlated with the histological resolution of the disease. And in conclusion, hypopigmented mycosis fungoides is more frequently described in darker skin phototypes, and its prognosis is excellent regardless of race, sex, or age. Although hypopigmented lesions may persist for many years, progression to the plaque stage has not been reported. This is currently a little consensus on 5 years survival matter. Hypopigmented mycosis fungoid has significantly less clinical skin features, emphasizing the importance of careful and meticulous physical and histological examination to get the right diagnosis. And thank you for your patience and attention. Now we will move to the questions. If there are any questions. There is a question about how to make clinically the difference between hypopigmented mycosis fungoides and others diagnoses like vitiligo and pityriasis alba. I think for pityriasis alba, I think it's toposigns who make difference. And now for vitiligo, it's a little bit difficult, but extension of lesion and Kobner phenomena are important. Also, it's a biopsy, skin biopsy, who make the difference.
Second question, what is the etiology behind mycosis fungoides?
It's a primary cutaneous lymphoma. Really, there is no, the etiology is not being understood until now. It's a type of lymphoma, of cutaneous, primary cutaneous lymphoma.
Can mycosis fungoides be misdiagnosed?
Of course. It misdiagnosed with vitiligo, with hyperpigmented post-inflammatory lesions, and with pityriasis alba, with leprosy. There are many diagnoses who seems like mycosis fungoides.
Okay, Dr. Ibtisam, last question. Does mycosis fungoides affect the immune system?
In rare cases, really it's a cutaneous lymphoma, and more reports in the literature, there is no immune, it's not affect the immune system. Now, back to you, Rachel.
Thank you, Dr. Ibtisam. It was a pleasure having you with us today. Now we are moving on to the 30 minutes of networking break. The next session will start at 11 a.m. Qatar time. See you.
This coming November the 1st, 2022, join us at the Conference on Dermatology and Cosmetology in Qatar. under the theme Recent Advancement Changing the Future of Dermatology and Skincare. This one-day conference will feature a wide range of topics that will discuss the latest developments and findings on dermatology, natural cosmetics market and skincare, and will include interactive sessions like panel discussions, presentations, workshops, and the opportunity to network with other dermatology specialists and practitioners across the globe. What are you waiting for? Join us on our exclusive all-in-one virtual platform and register now in our website.
Welcome back to the second session of Qatar Dermatology and Cosmetology Conference. I want to welcome our first speaker of this session, Dr. Kiran Godse, Professor of Dermatology at Patil University School of Medicine. Dr. Kiran Godse has 150 publications. He's the president of the Skin Allergy Society India and editor-in-chief Indian Journal of Skin Allergy. He has written 7 books with 20 chapters. He's also the president of Indian Association of Dermatologists, Venereologists, and Leprologists in 2020. Welcome, Dr. Kiran, and the platform is yours to present.
Hello, I am Dr. Kiran Godse, Professor of Dermatology from D.Y. Patil University, Navi Mumbai, India. And I am here to speak on urticaria guidelines. Next, please. Next slide, please. Yeah, as you know, my interest is being urticaria, and I have been a president of IDWell in 2020, and I'm editor-in-chief of Indian Journal of Skin Allergy. Next slide, please. So these guidelines were prepared in 2020 during COVID times with 64 authors, 50 societies, and 31 countries. One of the largest guidelines made in the world. They are made every 4 years, and I'm going to share with you what is new in these guidelines. Next, please. So as you know, urticaria is a disease characterized by appearance of itchy hives, angioedema, or both. So anybody can diagnose urticaria or angioedema. But please remember, if urticaria do not disappear in 24 hours, please think of vasculitis. Similarly, angioedema is a deep swelling. If you see a patient of angioedema without wheals, think of hereditary angioedema. Next, please. So urticaria can be classified as acute and chronic. Acute is less than 6 weeks and chronic is more than 6 weeks. Chronic is further subdivided into inducible urticaria and spontaneous urticaria. And spontaneous urticaria is further divided into the causes like autoimmune causes, idiopathic causes, and unknown causes. So we are concerned more about chronic urticaria. It can last up to 5 years. Next, please. So urticaria is a burden on the patient as well as on the society. It can affect physical well-being, socio-economic well-being, emotional, psychological, and it can function relationship of a person. Just imagine I am speaking to you and get a swelling on my face. What will happen to me? Or if I start scratching? So that's the quality of life affected. That's why urticaria needs to be controlled continuously with good medications. Next, please. So these are the two emerging endotypes of chronic spontaneous urticaria. One is autoimmune type 1, that is also known as autoallergic, and autoimmunity type 2B. These are two autoantigens antibody which keep on triggering mast cell to release histamine. So chronic urticaria is mainly either autoallergic or autoimmune. Next, please. So if you can see here, the mast cell is being activated by autoimmune pathway and autoallergic pathway. There are some other pathways also which are not yet elucidated. But the final result is pruritus, erythema, edema, and wheals. So autoimmunity and autoallergy are the two main drivers of chronic urticaria, and our whole research is now to find out what is this autoallergic urticaria. Next, please. So autoallergic is autoantibody to auto IgE type against TPO, TG, IL-24 or dsDNA. Type 2 autoimmunity is a true auto IgG mechanism which is against Ig and Fc epsilon R1. Autoallergy can be diagnosed by a specific Ig to autoallergens and a total auto IgE, whereas type 2 autoimmunity can be diagnosed by autologous serum skin test or basophil histamine release assay. Ig is normal or high in autoallergic, low in autoimmunity. Disease is less severe in autoallergic and more severe in autoimmunity. Concomitant allergic diseases are common in autoallergic type and autoimmune diseases are common in autoimmune type. Next, please. So US is the urticaria activity score which we recommend that all doctors should do. Just count the number of wheals and the severity of urticaria. Maximum score is 6 per day and 42 in a week. So you can understand the severity of urticaria by counting the number of wheals and its severity. Next, please. So this is a measure of severity. So somebody has got urticaria activity score of 28 to 42 has a severe urticaria, and somebody has got less than 6 is a mild urticaria. Next, please. Urticaria control test is the second test which is easy to diagnose. Gives us idea how well means do you modify. Next, please. So CSU is a chronic disease. Average duration is 1 to 5 years. At the end of 1 year, 50% patients will go into remission, and at the end of 5 years, most of the patients will go into remission, but less than 5% will have urticaria up to 20 to 50 years. Next, please. So average duration of urticaria is 5 to 7 years. So you need to control the disease for 5 years minimum to give a natural remission. Next, please. So these are the factors which control CSU. Those who have got a severe disease, females with higher age, concurrent angioedema, concurrent inducible urticaria, positive autologous serum skin test, metabolic syndrome, and NSAID hypersensitivity. If your patient has got any of these factors, these patients will have severe urticaria and it may last for 5 years or more. Next, please. So why urticaria is bad? Because 40% of patients' relationship suffers, more than 50% don't sleep well, more than 50% there is no constable, and they stop or reduce doing fun things. That's why urticaria is a disease where complete control is essential. Next, please. So again, this were considered that urticaria is a bad disease, can affect physical, socio-economical, emotional, and physical well-being. Next, please. So these are the new guidelines which are formed in 2020. Our first line treatment is start with the second generation H1 antihistamines, and if needed, increase up to 4 times. Second line is to add to the 300 mg every 4 weeks. And if needed, you can give it 300 mg every 2 weeks. And the third line is a cyclosporine. Short course of systemic steroid, maximum up to 10 days, can be given if there is a worsening of the disease. Next, please. So these guidelines will clearly show you how to manage. So to start with, you start with the H1 antihistamines. Remember, when you give only single dose, up to 50% of patients come under control. When you give updosing up to 4 times, 60 to 80% patients come under control. You can add second line omalizumab, which will give a better control of the disease. And some patients will need a cyclosporine. So again, a specialist opinion is required when you want to do updosing and add omalizumab or cyclosporine. A level up to general or family physician can do updosing and you try to control the disease. Again, short course of steroids may be considered during exacerbation. Next, please. So this is UCT, how to manage. If UCT is less than 12, patient, this is the dose. If urticaria control test is between 12 to 15, patient is well controlled, continue the same treatment. And if urticaria control test is 16, that is perfect control, try to reduce the dose. So that's the way you have to control the disease and give treatment. Remember, do not stop antihistaminic suddenly. Slowly try to reduce. If you reduce fast, patient will go into worsening. Next, please. So what is the rationale behind updosing? We know that the newer antihistaminics are low toxicity, the action is dose dependent, and there is an anti-inflammatory action also. That's why updosing is widely accepted all over the world as a first line treatment for urticaria. Next, please. Has been bilastine, which is one of the least irritating antihistamines, and the oldest one is chlorpheniramine or diphenhydramine. So our guidelines recommend that you must give second generation H1 antihistamines and not the older ones. So typically you should give levocetirizine, cetirizine, desloratadine, rupatadine, and bilastine and fexofenadine. Next, please. So is a negligible in drug adjustment required, and it is being widely accepted as a number one antihistamines for treatment of urticaria. Next, please. So bilastine is equally effective like can give sedation in 10% of patients. Next, please. So bilastine does not cause somnolence. That is the advantage of bilastine. So patient can take this medicine once a day, twice. Next. So as you can see, brain H1 receptor occupancy is very, very low for bilastine and fexofenadine. So these are the preferred antihistaminics during daytime, and evening, night time, you can give levocetirizine, cetirizine, or loratadine, but avoid giving hydroxyzine or diphenhydramine to the urticaria patients. Next, please. So why we say don't give old antihistaminics? Because sedation with older antihistaminics can create a poor sleep architecture. REM sleep is delayed and reduced, and patient remains drowsy throughout the day. So patient's quality of life is bad. Next, please. Omalizumab is the number one drug which is available for control of urticaria. It prevents angioedema, improves quality of life, and suitable for long term. It can be given 300 mg per month subcutaneously, at least for 3 to 6 months. And now we have got a biosimilar of omalizumab. Next, please. Cyclosporine can be given those who do not show response to omalizumab. Dose is 3 to 5 mg per kg. It's immunosuppressive effect. Please check CBC, creatinine, and blood pressure when patient is on cyclosporine. Next, please. So, workup of urticaria is important. Exclude differential diagnosis, rule out inflammation, and measure disease activity and impact. Next, please. CBC, CRP, ASR, total IG, and IgG anti-TPO. These are the 4 tests you must do in urticaria patients. This will give you a guideline whether patient is autoallergic type or autoinflammatory type. Next, please. So IG is a indicator. High total IG indicates autoallergic type, and low IG indicates autoimmune type of urticaria. So this will give you a guideline what to use. Next, please. CRP is linked to urticaria activity and coagulation marker. High CRP indicates ASHT positivity and autoimmunity. Next, please. So basopenia on a 5-part cell differential will give you a clue that basopenia indicates Next, please. Of autoimmune urticaria. Next, please. So positive anti-TPO antibody and low IG is a best surrogate marker for chronic urticaria autoimmunity type 2. Next, please. Again, what you need to do is avoid triggers, rule out infection, do the check for thyroid gland, TSH, and autoantibodies, and biopsy if you suspect vasculitis, and serum tryptase level if you suspect mastocytosis. Next, please. Out for the cause. Look for the co-factors like autoimmunity and mental health. Look for the consequences with sleep, distress, sexual health, work, and social performance. Look for the biomarkers and follow the course with CSU by doing UAS and UCT. Next, please. So this is the algorithm to find out how to go about urticaria. So basic question you must ask if patient got unexplained fever, body ache, malaise that gives urticaria do not disappear in 24 hours. Think of vasculitis and a biopsy. If there is angioedema without wheals, think of hereditary angioedema. Next, please. Next. Other options are Montelukast, ranitidine, methotrexate, dapsone, autoserum therapy, and doxepin. Next, please. So Montelukast is useful in respiratory allergy and NSAID-induced urticaria. Next, please. H2 antihistamines has got less evidence, but you can try ranitidine 150 mg twice a day, which is safe and economical. Next, please. Seven tablets of urticaria. This is a formula which you can use if you do not know what to do. Give 4 tablets of antihistamines, 2 of bilastine or fexofenadine in the morning, 2 in the evening, levocetirizine and loratadine, 2 H2 antihistaminics and 1 montelukast. If the 7 tablets do not give control of urticaria, think of omalizumab and cyclosporine. Next, please. Methotrexate can be given 10 to 15 mg per day along with folic acid. Check for CBC and LFT, but it's a slow acting and immunosuppressant. Next, please. Mycophenol mofetil can be given 1 to 2 gram per day. Next, please. Dapsone can be given 100 mg per day. It is useful in vasculitis and delayed pressure urticaria. Please check G6PD and CBC. Next, please. Autoserum therapy is a poor amount biologic. Collect blood and inject serum intramuscular or subcutaneously 2 to 3 cc every week for 9 weeks. 1/3 patient will respond. Patient like this injection therapy and it is safe and economical. Next, please. Start with the lower dose and go up to second 2 times and 4 times the dose. There is a strong consensus for this. Next, please. In pregnant and lactating human, loratadine is safe, followed by levocetirizine, cetirizine, desloratadine, and fexofenadine. But no updosing is advisable in pregnancy. Next, please. So these are the newer therapies for urticaria. Ligelizumab is discontinued by a company, but now we have got fenibrutinib, which can be useful, and other MAPs can be useful, but immediately there is no new biologics will be coming for urticaria. Next, please. Summarizing, second generation H1 antihistamines are the updosing is the first line therapy. Omalizumab with updosing is second line, and cyclosporine is the third line therapy based on the evidence. Next, please. Indian of Skin Allergy is available online free. Please submit articles and read to know more about urticaria. Next, please. Please join Dermacon International 2023 in February 2023, one of the largest event in Asia. Thank you for your attention.
Thank you, Dr. Giran, for sharing your knowledge. Now we will move forward to our next speaker, Dr. Saif Al-Azzawi, Head of Plastic and Cosmetic Surgery at Amman Hospital. Dr. Saif is a UK-trained consultant plastic and cosmetic surgeon with CCT in plastic surgery. He worked as a consultant plastic and cosmetic surgeon in England at the National Health Service and in private practice in London. He holds an FRCS plastic surgery from the Royal College of Surgeons. He has completed several advanced specialty fellowships in Australia, including the Advanced Aesthetic Plastic Surgery Fellowship at Melbourne Institute of Plastic Surgery, Body Contouring and Liposculpture Fellowship in Sydney, and Microsurgery Fellowship at Royal Adelaide Hospital. Welcome, Dr. Saif, and the platform is yours to present.
Thank you very much for this very nice introduction. It's a pleasure for me to be here. And I'm really enjoying the talks that I'm listening to. Something's very enlightening, very inspiring. So thank you for this. I'm going to go straight through. So before I start, a few important points. Now, as a plastic surgeon, obviously I do cosmetic surgery and our specialty are very visual. So there'll be some photos of patients that have consented for me to use their pictures for education purposes. Very important for me to say that please don't take any pictures of the patient photos that you see here on the screen. And also need to discuss about potential conflict of interest. So I've recently moved from the UK to Qatar. I was in private practice and in government practice. So I'm new to this country. In terms of financial conflict of interest, obviously I'm the head of Department of Plastic Surgery, Cosmetic Surgery at Amman Hospital, but I'm also a trainer for dermal fillers and thread brands here in Qatar. Otherwise, no financial conflict of interest to declare. So just quickly regarding my background, as we've discussed, I trained in medicine in the UK. I went to medical school in University of Glasgow, and then I did my entire residency program in the UK between Manchester and London. Then I went to do my fellowships in Australia. And then after 2 years of work in England, I now find myself in a new environment here in Qatar. So it's a very different area to practice. And I'm hoping to bring some of these differences into the conversation today. Obviously, the talk is going to be geared towards why we think having a plastic surgeon involved in a weight loss journey is going to be better delivering a outcome for the patients. And this is a combination of my personal experience over the last 12 years working as a surgeon, but also from research that we've done in one of the Centers for Obesity Surgery from my previous role. So in my talk, I'm going to talk about 3 myths, so 3 things that are maybe not true and we should debate them, and also 3 key philosophies. In terms of the philosophies, these are things that I have gathered through my career and also things that I have learned from professors and people that I've worked under. The first one that I'm going to mention is, in your practice, try to under-promise and over-deliver. If you do that, you'll always have happy patients. This is regardless if you're a cosmetic surgeon, cosmetic esthetician, doctor, injector, dermatologist. Stick to that process and you'll have happy clients. The second thing is do good work. And one way to look at it is treat people like you think you're going to treat your friends and your family and how you want them to be treated. If you do that, then the people will come to you and you'll build a reputation and a name. And the third one, and the most important one, in my opinion, is know your limitation, know yourself, because you build your reputation on the patients that you say no to. If you're faced with a situation that's quite difficult. So try and stay humble and be humble in your practice and always learn from colleagues and always learn from patients. That will do you a long way. So the first myth we're going to start with is plastic surgery is all about boobs and Botox. Obviously, you guys are familiar with the work that we do. We do surgery wherever there is skin. In fact, we are integument surgeons, if you want to call it that way. So whilst cosmetic surgery is a big part of what we do, whether the surgical, cosmetic body contouring and the non-surgical element, obviously we do reconstructive surgery. And post-bariatric surgery, after significant weight loss, falls in the remit of between somewhere cosmetic and reconstructive. And the reasons are the operations that we do actually help people functionally. And I'll come and explain why that is the case. So in terms of that myth, there's something to bear in mind that we're doing something that's more than just cosmetic surgery when it comes to helping somebody who has lost a significant amount of weight. Now, just a bit background to this study. This was done at Luton Dunstable Hospital. So for those of you who are familiar, who visited the UK, these are the collaborators that I've had worked with. And essentially, we worked in a center that does a high volume in terms of bariatric surgery for weight reduction or metabolic surgery. The majority of the procedures were laparoscopic Roux-en-Y gastric bypass, and also there were some sleeve gastrectomies. Interestingly, both of these procedures are very common here and very popular in the state of Qatar, as well as throughout the Middle East region. So this is why something I'm passionate about in my work here. So obviously bariatric surgery, regardless of the type, they result in a significant looseness of skin. One patients lose the excess body weight. And this loose skin and fat envelope that troubles them and throughout the areas of the body is the reason why they come and seek our help for skin reduction for cosmetic surgery. Now, what we try to establish is the significant impact that this has on their activities, both from a physical perspective, so in terms of being able to clean themselves, wash themselves properly, but also mental health and mental impact in terms of the body image issues, finding appropriate clothing, how they see themselves, and also having issues with sexual intercourse and dysfunction in the bedroom. So this was the reason why I wanted to look at this, try and stratify the impact of how those people are feeling. Now, I must say, this study was conducted in the UK, so the patient population are different to the ones in the Middle East in terms of being able to openly discuss or talk about such issues. But with that, we also made sure that everything remained anonymous, and we carried out this research with that was totally anonymized, so no patient's information were shared. So the way we did it is we've gotten in touch with 151 patients that were done consecutively who've undergone basically gastric bypass surgery at the center. And this questionnaire that was approved by our research team went out to all of them, and then we waited for them to return it. And it had some specific questions talking about their impression, their weight loss journey, where they are at the moment, and also the impact, both physical, functional, and emotional, of the excess skin that this has had following their weight loss operation. Now, we've had so 97% of the patients were confirming that what we already know, that they would like to have access to plastic surgery, but unfortunately only 23% of them who were surveyed have had access. And this is to do with a lot of factors, mostly in terms of funding, availability of plastic surgeons, and the plastic surgeon being within the first one. So these are the issues that are available. Now, we talked about physical issues, so back stress, hygiene, difficulty with clothing, emotional distress, and the other issues that come with amount of excess skin. Now, interestingly, we wanted to find out the order of how people find it in terms of the priority. These are pictures of my patients that I'm showing. So obviously, the number one priority is the abdominal skin excess. That's the area of the majority of the problems. And then second place comes the breasts. So people need to have breast lift or breast reduction even. Then is the arms, then the thighs, and then finally we go back to the posterior surface of the patient, so the buttock, and finally the back. Now here there's a variation in terms of when people want to have their facelift and their neck lift done, because obviously when you lose a significant amount of weight, that will accelerate the aging process in terms of the face and how the neck looks like. Now, I'm going to talk about myth number 2, which is bariatric patients don't care about scars. It'd be interesting to see or to hear your points on this, but from my experience, patients come to me and say, "Doctor, I really don't care how the scar looks like. I just want to get rid of this bit of extra skin. These rolls or these bits of skin are so annoying, I don't mind having the scars," which actually in turn means we've done more surgery on those patients than we otherwise will. The key thing that has driven this this piece of work is patients who come and sit in the clinic who they're desperate, and they will say, "If I knew I would look like this after the bariatric surgery, I wouldn't have done it." And in contrast, when we survey them after abdominoplasty, they have a 97% satisfaction. So the conclusion and recommendation we made from here was that actually, if we add a plastic surgeon as part of the team to see them before they go through the journey, set the realistic expectations of the patient, show them some pictures and show them what their journey would look like, and be there as a port of support, that will improve their overall outcome. Now, when we talk about the multidisciplinary team, so people who have bariatric surgery, particularly in the UK, they don't just go and see the surgeon and then have the operation. It's actually a long process involving seeing a psychologist, a dietitian, an occupational therapist, a physiotherapist, and a bariatric surgeon, and the whole nursing team. So what we've done is we've incorporated a plastic surgery consultation within the initial consult, and then that will then take it forward. Just a quick point here that we have about 6,000 patients waiting on the waiting list in Qatar for bariatric surgery. And the waiting list for abdominoplasty is about 4 years. In this picture, this is called a fleur-de-lis abdominoplasty. So the scars are up and down in the middle and also transversely. So in conclusion, working together is always better, and there should be a plastic surgeon as part of the MDT to improve the overall satisfaction. The final myth is the face. Like I said, people come and see us at various points throughout the journey for that. But in an ideal world, like we said, working together and collaborating. Yeah, these are the 3 messages. And if you have any questions, I'd be more than happy to hear you. Also, I've left my details in here to get in touch. I'm all for collaborating and working together because I believe being with the group and being within your peers is always better for our work and for our patients. So thank you.
Dr. Saif Azawi, we will start now with the questions. Exactly on which point in the weight loss journey will it be useful to see a plastic surgeon, and also how many times and how often should this consultation happen before the patient goes to bariatric surgery?
Let's just skip the question for now, because I think we might be tight for time.
Okay, can we just answer this question as it was shared?
So I think that we should basically see the plastic surgeon in the initial consultation, and then once actually is enough until they've had the surgery. So see them once until they've had the bariatric operation, and then start seeing them once they have hit at least 20% of excess body weight.
Thank you, Dr. Saif, for your insightful talk. The next session is also taken by Dr. Saif with the topic Social Media Body Image Disorder, a new diagnosis facing cosmetic surgeon. Dr. Saif, the platform is yours to present.
Okay, so this is going to be a presentation about describing what we think is a new diagnosis that we've termed social media body image disorder. This comes from the work that I have done in my fellowship in Australia with Dr. Laith Barnuti, one of my colleagues, who's a co-author on this paper that we've published. So I'll start with the bottom line up front, which means the key message. We believe that the influence of social media on body image warrants its own diagnosis. And that's why we've come up with this term. And the key for discussing it here with this platform is to make raise awareness, helping other clinicians and patients to understand about this condition in order to not have unrealistic expectations of the cosmetic procedure. But let me start generally about what is body dysmorphic disorder. The classical diagnosis is essentially when people have a mental health condition where they have an obsession with part of their body that they feel is completely flawed, and they believe that it needs to be altered or hidden. And this gets to a point where it significantly takes over their life, and they'll go through extreme measures to try and hide it or fix it. Now, this can have a crippling effect on the physical and the mental health of a person, including people who go into anxiety, depression, or more seriously, trying to attempt to take their own life as a result of what they see or they think that they see. I'm not going to go through the full details of how to diagnose body dysmorphic disorder, but this is available in the sort of ICD-10. But essentially, it's about having preoccupation with a flaw, and then doing some repetitive behaviors such as checking it, seeking assurance, and also having a significant distress or impairment socially or occupationally as a result. But also, the key thing is that this is not related to their eating disorder. So it's a separate, more of an anxiety-driven type condition. Now, this is the classic body dysmorphic disorder that we get trained as plastic surgeons and cosmetic surgeons to diagnose the patient the moment they walk in, because they will not be happy with whatever we do to them. There are lots of images of how people actually see themselves. Unfortunately, it's quite common in the younger generation. We think the diagnosis is around 1 in 50, but we don't really know. I suspect probably higher in the Middle East compared to Europe, just as from my brief area of practice that I've seen so far. I won't bore you with the etiology, but we think, like many mental health issues, it's very complex. It's to do with emotional and physical development and time during childhood. And obviously having a genetic susceptibility. So these negative persistent thoughts might lead to ideas of depression, self-harm if not managed properly. And obviously the social impact and the cultural environment tends to alter them. Now, how we normally treat body dysmorphic disorder, unfortunately, it's not a very easy situation to be in, but like any other anxiety conditions, they treat it with antidepressants and with cognitive behavioral therapy. But the key perspective from a cosmetic person, whether a surgeon or dermatologist or an injector, you need to diagnose the person that you think has this and make sure that you don't operate on them. because you will make them miserable and they'll make your life difficult. You might have come across this mnemonic, this somebody that we call Simon. You know, just lots of features that how to spot somebody that we think will be a bad candidate for any cosmetic work. This is where I think being a cosmetic surgeon is kind of like speed dating in a way, or like profiling people like you're in an airport. Instantly you have to decide when they come in, do you like them? Do you trust them? Do you think you'll make them happy? And do they seem normal, or could they have unrealistic expectations? So that's, again, body dysmorphic disorder, the standard pathway. Now, what we are terming now is social media body image disorder. This is where we found a significant link with what we believe should be an alternative or a different diagnosis, particularly for the younger generations with significant exposure to peer feedback, obviously being able to take pictures and sharing them and getting feedback on them instantly. Also, some studies show that selfies do an over-evaluation of the size of the body part. So those people tend to become vulnerable to what we've termed social media body image disorder. So again, similar to the standard, body dysmorphia, it's negative thoughts and feelings about their own body, but here is directly influenced by their own engagement with social media. So you'll find that people who are repetitively examining the body parts through zooming in and out, once they take a picture, they're taking photos from different angles to try and minimize what they see as a flaw, taking photos from different angles of the body that are not normally ways to take a picture because they want to examine the flaws that they have, and of course using filters and modification in a sort of excessive way. And the last 2 points in terms of publishing the photos and then feeling self-anxious about them. So there is a direct link, and that's been identified, between social media use and the development of body image disorder. And that can lead, again, to anxiety and significant impact on how people view themselves. So people tend to come and see us often wanting to look like the filtered version, or the Snapchat dysmorphia term that has been used. To try to explain it a bit more, we looked at how this is happening, and we think maybe there's a social cultural model to suggest that it's basically a response to lots of sources of influence into the perception of the person's body, and social media being a normal way of doing it right now. Now, when people create an ideal and they can't aspire to reach it, that's when the dissatisfaction happens, and that then triggers them into the cycle of anxiety and trying to change that. Now, obviously, we are guilty, perhaps, because we are posting lots of pictures of before and afters that are attacking people on our social media and Instagrams. In fact, one of the things I noticed in Qatar is that here, you're not allowed to use before and after pictures. Nobody should be doing that for lots of reasons, but I think ultimately it's actually a smarter way to try and deal with an issue that has affected particularly the younger generations all over the world. So it'll be interesting to see how this has an impact. Then obviously there's the influence of marketing in terms of peer pressure, in terms of how marketing uses those images and editing the images. So sometimes they're not really true. It's just that you're seeing what the media wants you to see. So if you had somebody who's a young, vulnerable teenager who wants to follow the trend, who doesn't want to be left out, has fear of missing out, then they're an ideal candidate for these sort of issues. So how are we going to try and help the situation? Well, we think that maybe using a recognized questionnaire, such as the social cultural attitude towards appearance questionnaire, or SATAC. If you see somebody in your practice who might be potentially a risk of having this condition, then getting them to have a look through this questionnaire, that will help you pick up the red flags that we think could then prevent you and the patient have a significantly negative outcome if you go down that route. So in conclusion, as society becomes more connected via social media and with the internet, plus the increasing pressures that we're being exposed to and that's been exerted on the adolescent population, we might be seeing more of this. There are unrealistic expectations on the appearance and the body image that will relate to development of body dysmorphia. So this coupling is what we believe has created this new diagnosis of social media body image disorder. And then being aware of it, trying to educate your colleagues about it and your patients, and maybe using this questionnaire might be one way of avoiding a potentially disastrous outcome. And in terms of the future, as we know, we're starting to use the metaverse now. Things can change themselves, people can change. So maybe there might be a point where this will no longer matter. But for now, I would love to hear your thoughts. I've left my number here and my mobile for collaboration. So yeah, thank you very much. I'm happy to take any questions now.
Okay, Dr. Saif. So first question, what's the role of having a psychologist as a part of the cosmetic treatment or cosmetic surgery team? And what would you do if you don't have the psychologist that you can access?
So it's actually a very good question. Psychologists have a significant role. And if we are fortunate to have somebody that we can work with as part of the multidisciplinary team, again, you see this is my thought about working together, then that helps us significantly. But unfortunately, they're not always available. They're a very scarce resource. So if you don't have one that you can work with, you'll need to ask for help from other colleagues and maybe also get to learn yourself about how to manage this in the same way that a psychologist would do. Now, I'm not suggesting that everybody should train as a psychologist, but having some insight into their world and having some strategies to help patients, or at least direct them in the right way. This is what I would suggest.
Second question, when identifying the patient body is more fear or body image overall, then how do you tell them that you don't want to do their surgery or how do you get out of doing the procedure?
That's also a very good question, and it's actually very difficult. It's not easy, and with time you need to develop an ability to sort of softly being able to very gently talk them out of it. But also not be ashamed to say, look, I don't think I can make you happy. I don't think I'm the person that will be able to deliver what you want. And being open and honest about it. And again, going back to knowing your limitations and using that and just say, I don't think I can do this for you, but, you feel free to look for somebody else. It's not an easy discussion and it's not an easy conversation, but yeah, this is what we need to do.
Thank you, Dr. Saif. It was a pleasure having you with us today. I would like to mention that we have as of now more than 700 global attendees watching us. Let us move forward to the next session and introduce our first speaker, Dr. Hala Mackenzie, dermatologist at Marble Medical Center. Dr. Hala has done her master's in dermatology and venereology at Aleppo University, Syria. She's also a member of the Syrian Arab Society of Dermatology. Welcome, Dr. Hala. The platform is yours to present.
Hello, good morning. Assalamu alaikum. I'm Dr. Hala Mackenzie. It's my pleasure to be with you now today. Always as a dermatologist, we try to speak about the benefits of Botox and fillers. But now I want to speak in the opposite way. How can we delay the need of Botox and fillers? Right, okay, well, this question, how can we delay the need of Botox or fillers? In cosmetology, specifically in the anti-aging procedures field, there is nothing obligatory. I mean, if the cardiologist finds that his patient has high blood pressure, the doctor will not ask the patient, oh, my dear patient, would you like to take any drug to make your blood pressure lower or no? He should confirm and he should tell him it's necessary to take this drug to help you to don't have more complications. But in our cosmetology field, we can make a big or long discussion with our patients. He has a right to choose the procedure that fits him. Maybe he wants to make anything cosmetology without fillers or Botox. He likes to be like a more natural looks without changing anything or make volumizing. So we are going to see the procedure that can help us in make collagen stimulation. Here is the difference between the younger and older skin. Here, the younger skin, as we see, we have dense of collagen and elastin fiber. Comparing with the older skin, you see there is elastic fiber are broken and collagen atrophy and less hyaluronic acid. So, as we age, many unwanted spots, lines, creases often caused by accumulated exposure over the years and multiple causes. So how about the voice? Is it good? Okay, we can see like dark spots. We can see sagging skin. This from the aging, what's happened that we lose our laxity in our skin. Here you can see less contouring, more deep nasolabial folds, and here we see less definition of our jawline. So till the skin, the quality of skin change. So you can see that the skin is less glowing, dull, dry. We can see patchy skin as we age. Right. At what age does collagen production decrease? Okay, the collagen will not stay forever and stop the collagen production. So this age is mostly about 30 years old. There are some people stop before, maybe 25 or before. It depends on genetics, and some people may stay more long time having collagen production. And year by year, we lose 1% or 2% of our collagen. Okay, if we put our photo today and the year before, we'll not see a big difference in our faces. But if we put every 5 years, really you will see there is difference in your face, like under your eyes. The quality, the laxity of your skin will change. Here, as we see how this change in our collagen, like how do we preserve collagen? Okay, it depends in two ways: the lifestyle and the procedure. The lifestyle, as we know, it really affects a lot our face, our collagen, our body. Healthy life habits like food, sleep, sport, avoid smoking. Till when we take the supplements, most of our patients ask us about the supplements of collagen powder or collagen serum. Do they have any benefits? Actually, when we drink these apples, it's not collagen exactly. It's not collagen because collagen is very big protein and can't be absorbed from our stomach. It's peptides which go to the blood vessels and the bloodstream. They go to our skin and they promote more collagen in our skin. And really, the patients after 3 months taking of these powders or syrups, you will see difference. Till for the collagen craze, as we see in the market, there is collagen. Actually, it doesn't have collagen to our skin. So it's the same. It's like stimulator for collagen peptides that can stimulate collagen, which is the most important component in our skin to keep your skin healthy, fresh. And we consider for our patients for the daily skin routine, especially for the sunscreen protection and the moisturizer. They are the most important things. Here I'm speaking for the patient, maybe they don't want to enter to the dermatology clinic. They just want to have daily skin routine and healthy life habits. This is one big stone in our life that you can help you. And if you want better results, we can enter to the cosmetology clinics and ask for a procedure can help to promote collagen in your body. So we are speaking now about the procedure could be done in a clinic and help you to have more collagen production in your body. What is the most or the best procedure or injection can doctor use to manage aging mechanism? This question very familiar in our clinic. What's the best injection or procedure? Actually, it's not one injection, it's not one procedure. Can doctor do it to manage aging? It depends on the patient's age, gender, if there is any disease, skin color, previous procedures, and the most important thing when we decide the procedure, the expect of the patient. Always we tell you in cosmetology, there is nothing magic. Yeah, I mean, there is no one needle, one session that will change you from A to Z, from 0 to 10. It will be accumulated things helping between the doctor and the patient, multiple maybe procedure if we need in case that the patient didn't take care a long time about his skin or his skin. So the most common anti-aging procedure, by the way, I want to tell in my personality, like a doctor, really I like this anti-aging procedure. Maybe I like it, yes, to encourage my patients to make it more than Botox or fillers. I don't mean that we don't need Botox or fillers. In some stage, we can't remove this wrinkle or we can't deal with this problem that patient has without Botox and fillers. Now I'm speaking before we arrive this age that we can't do anything without Botox and fillers. What's the anti-aging procedure? Always my patient asks me, doctor, you think, do I need to make this rejuvenation? Do I need to make this peeling? I want to tell you something. When we speak about Botox and fillers, yes, I tell patient, maybe I tell you, yes, you need, maybe you don't need. But when we are speaking about rejuvenation and anti-aging procedure, in my opinion, it fits all people. All people needs to have this glowing in their face, to have a fresh skin. And any anti-aging procedure you are making now, it's not just for now, for these 5 minutes you will have the results. You will keep have it in the older age. I mean, if you bring two sisters, they have the same genetics, the same of lifestyle. If there is one sister always keeping to make rejuvenation procedure between dermapen, lasers, and another sister, she didn't make anything. After 10 years, sure, the one sister who is keep taking care about herself will be more natural, more healthy, more younger. That's sure. Comparing with another sister that she didn't make anything. So, what are the most common anti-aging procedure? We have mesotherapy, platelet-rich plasma, hyaluronic acid, both cross and non-cross linked, ablative and non-ablative laser, microneedling, and ultrasound. What's meaning of mesotherapy? Mesotherapy, meso means the mid of the dermis, and therapy means treatment, okay? So how can we insert it to our skin? We have two ways. Either we inject it by small needles, and we prefer this for more women who can tolerate injection. It's not very painful, but it's injection of needles. And they don't have any problem to have a little bruising. And there is another way that we can insert this mesotherapy solution by devices which open channels inside of the skin, like the dermapen or microneedling devices. So, what are the mesotherapy? It's multiple materials. So it may be arginine, like which make Botox effect. It may be vitamin C, which antioxidants and giving glow to our skin. Which may be the MAE, which help to make stronger and denser for the skin. Caffeine, hyaluronic acid, glutathione, which can help to make more whitening to your skin. Vitamin A, or as we call the like retinol, which can help to treat your pores and another problem in your skin, and all try to make stimulation to your skin, collagen to have more healthy skin. Platelet-rich plasma. This is the yellow solution that we need. So what's the benefits from the plasma? I want to tell you, when we have any problem in our skin and damage, like when we have the wound in our skin, platelets are the first responders. Why? Because they have multiple materials that can help to fix your damage to your skin, to your blood vessels. So they think, the scientific people think by this way, we don't take these materials which help us in our skin. And it has multiple materials like transforming growth factor, fibroblast growth factor, insulin growth factor, and multiple materials that have a signaling between the cells to treat and to help you to fix your skin. But when we are injected to the face, what are the most important results? It's not just in the face. I want to tell you that the PRP can be injected to the hair, and we can inject it, not like dermatologists and other doctors, archaeologists, can inject to the joints to help them. So what the benefit from it? It can make collagen stimulator, new vascularization, collagen remodeling, and it helps a lot in acne scar or any scar that we have it in our face or in our body. Dermathickening, stimulating of fat growth factor, improve the volume that has lost to fat atrophy, and wrinkles improvement. So how can we do it? We can do it, as I told you, by injection directly to the skin, or by dermapen, and really it has a big and good results for the black under the eyes. Now we are going to speak about the hyaluronic acid with both cross-linked and non-cross-linked. What's the benefit from hyaluronic acid, and here what difference between it and fillers? Here our target for the hyaluronic acid not to give volume to the face. And I insist again for this speech not to give volume to the face, because really there are a lot of patients don't like to add any volume to their face. They like their face to be natural as it is, contour, no changing in their expression. So here we can tell them or use like this cross-linking and uncross-linking hyaluronic acid, which is going to give them rejuvenation to the skin. Here, as we see, we have a dry and tired skin. Here, we added skin booster as a dermal reservoir for hydration. It will not be immediate result like fillers. The patient after the injection will see a little edema in his face. This is not the result. Then this hyaluronic acid will spread in your dermis, and note here the difference between the skin epidermis in the middle and here. It's become better. Why? By the benefits of the hyaluronic acid itself, and because this hyaluronic acid is big lover for water, so it absorbs water more and more. Okay, skin booster, as we see, as I told you, here the hyaluronic acid doesn't function to have any volume. It's just to hydrate and pulp deeply our skin, so it will give you rejuvenation. We can do it this for the face, and special concentration we can do it under the eyes. We can do it for neck, décolleté, and the hands. It helps you a lot. So what the benefit from the skin booster? It improves in depth the hydration of the skin, make the skin more elastic and firmer. I want to tell you something. If you try to pinch your skin, if you feel that it's easy to pinch it and stretch it, this means you have a skin laxity. If you compare it with a small or young child, 5 years old, and try to take his skin, you'll see it's firmer. This is the effect that we are going to try to make it to our patient. More the skin, more elastic and firmer. That's what we need to avoid laxity and to avoid this undefinition to the jawline and other parts of the face. It can help you to smooth the skin, improves the texture of skin, wrinkling, slow skin aging and aging skin. This is all slower. So it's not that just the benefit that you will take it after the procedure. No, you have glowing and you have more hydration to your skin. This injection will help you to slow the aging process, delay the appearance of the first wrinkles, fills existing wrinkles. We can add it for a small wrinkles, especially if it's cross-linked, and revive collagen production by the body. What's the difference between cross-link and non-cross-link? Cross-link, which means that the hyaluronic acid parts catch each other. And we can find it in some of skin booster, but in very low degree comparing with fillers. Fillers, it has very high cross-linking and stays. As I inject point for fillers, it will stay like here. It will not spread for another place of the face. But as we inject the material, for example, like Profile, which doesn't have any cross-linking, it doesn't stay here. It will spread for about 4 centimeters for all the face to lift it. We put it in multiple points. Can we find aging without injection? Again, why we ask some question like this, it's our patient's question in the clinic. Sometimes they don't want to have injection. Mostly they are men. They don't like to have injection. They don't want to try the pain, and they don't want to have a bruising over their face. And there is some female always try to have this rejuvenation procedure without injection, like the older female, they don't tolerate for the pain. So there are multiple devices can help in skin rejuvenation. Here we are using the lasers devices, not only the lasers, multiple devices. First of all, like carbon laser, it's not an invasive procedure. I mean, I will not inject anything in the face. It will be superficial. So with multiple sessions, again, with carbon laser, it's gentle device. It doesn't have a very high changing to the epidermis. It's not ablative. And here the difference between ablative and non-ablative devices. Carbon laser is not ablative. It doesn't make any damage to the epidermis. So it doesn't have any downtime. The patient can finish and go immediately and live his life without any redness in his face. And now we'll speak again about ablative lasers, and we'll see the difference, comparing the difference between these two devices. Carbon laser, it's non-invasive procedure, as we told. It reduces fine lines and wrinkles with multiple sessions. You will not see magic from the first session. tightness, dilated pores, reduce acne and scars, and post-acne discoloration. How can it reduce the scars? As we told, the scars, it's mean, especially acne scar, it means destruction of the collagen. So here we need any methods like carbon, fractional laser, injection, anything can help to remodeling and rebuild collagen again. So as we tell you that carbon laser, one of these devices can help to remodeling the skin. Removes dead skin cells from the superficial epidermal layer, stimulate collagen growth, improve skin texture. Really, they treat this patient because we remove this superficial, the uppermost layer of the skin and improve the quality of the skin. Clear pores to reduce blackheads and whiteheads. Fractional laser, like it may be erbium and the most aggressive, which is CO2. They are non-invasive, as we told, like carbon. There is no injection will penetrate your skin, okay? But it is ablative. So what's meaning of ablative? As we told before, there is damage will be to the superficial area of the skin. It will make like this small points and it will make redness. And this redness may stay more than 4 days. So it has a long downtime. The patient should avoid the sun as long as possible. And sometimes with the patient, especially if they have dark skin, you should stay at home. You don't see the sun at all. So what the benefits of fractional laser? It will help us in skin pigmentation and in photoaging. Surgical and acne scar use it a lot really in acne scar, and when the patient have a surgical marks in his body like tummy tuck or another surgery, it helps a lot in these cases. The thallium laser, which is called laser, it's like carbon, it's a very gentle device. So the patient will have a little redness over his face for 1 or 2 hours, not more. It is like roll and laser at the same time. So it makes very superficial channels still as we can see them. It will be seen as redness in the face. It helps us in the facial rejuvenation, anti-aging effect, improves the skin laxity and texture by collagen stimulating, less fine lines and superficial scars, smaller pore size. And here we have multiple ampoules we can use it. So we have multiple vitamin sprays in the pharmacy, okay? But when we use it and apply over our face, some will be absorbed and some will not be absorbed because there is skin barrier, okay? So here is the device of vitamin laser, as it's known, thallium laser or vitamin laser. It makes channels in your skin, and these vitamins, as you see here, vitamin C, A, tranexamic acid, will be prepared at the same time you are working. We put it here, and it will be prepared and mixed at the same time you are working for the patient. So when we finish the session to our patient, like the laser time, we'll apply this serum. And so it will penetrate immediately and give very good results because the serum is fresh and all will be absorbed. High intensity focused ultrasound, or as it's known, HIFU. HIFU is relatively new cosmetic treatment for skin tightening that some consider a non-invasive and painless replacement for face. So sometimes people did non-surgical facelift. It uses ultrasound, like the echo that we used for the woman who is pregnant. It's used ultrasound and for a special area for the face, and it will help in collagen stimulation. So again, we will not see the results immediately. I mean, the patient, there is no difference of his face because it depends on the collagen stimulating. So you can see the results after about 1 month, and it continues for about 3 months. Microneedling radiofrequency, one of the amazing procedure. It helps in 2 ways. First of all, we can make it for a wide area like the neck, the face, the forehead. With the same tip. So for me, I tell my patient the cheapest procedure that you can make it and cover a wide range of area. It will help in collagen stimulating, so tightening for the skin. And another way, these channels that it opens, it helps us to insert any material, to put it topical, like any material we need, like PRP, SPM5, which are DNA, any material over the face and will be absorbed, so it will help again. And I tell my patient always, this device works in 2 layers. HIFU work just for collagen stimulator, but microneedling will work for collagen stimulator and work for your epidermis. You will see difference. in your pores and in the acne scar treatment. It helps fine lines, wrinkles, stretch marks, large pores, acne scar, hyperpigmentation, hyperhidrosis. And another procedure that helps in facial rejuvenation. Did you speak for everything? Did we miss anything? Yes, I want to tell you now cosmetology become a very important field. And always people try to find new ways to stimulate more collagen and to make rejuvenation for the face. So the science doesn't stop looking for new techniques to find methods work as anti-aging. One of the lovely procedures, they are monothreads. There are two types of threads. Threads which are mono, that you put it like this. Here inside of this needle there is a thread. We put it inside the skin and then we take these needles. The monothreads will stay in your skin. What's going to make? It's going to make collagen promotion. So you will see less pores, more rejuvenation, and we use it for acne scar treatment. And there is another type of threads. I didn't speak of it here because I see it's resembled for fillers and bottles. The fourth threads we insert it here from up until down and make lifting to the face. That type of threads it helps in immediately affecting lifting results and in promoting collagen. But this mono threads, it's less aggressive and doesn't have a lot of downtime. Maybe just a small cruising you will have it. Chemical peeling, which is amazing procedure, especially if you have a white skin, because for the dark skin, we can't be very aggressive to the peeling to avoid having any problems of hyperpigmentation. In the end, don't forget to keep healthy habits in your daily routine to keep your body healthier and your skin younger. Always, I tell the patient, you can't live in the dermatology clinic. You can stay each 1 month or each 1 week stay with us. I always recommend them to make 3 sessions of any thing that they need. Maybe my patient needs 3 sessions of microneedling, radiofrequency. Maybe my patient needs 3 sessions of stem cells with dermapen. I recommend them to make it 3 sessions, 1 month between each session, and to make 1 session after 6 months. It's like a reserved session. And between these times, you should take care about your skin. It's important to apply sunscreen and put it again after 2 hours, because don't put it in the morning from 7 o'clock until 4 o'clock p.m. It will be, the effect of the sunscreen will be decreased a lot, and it will be gone with putting face mask and with sweating. So don't put it for a long time. Put moisturizer, it's very important, especially the area under your eyes, it's very important. And to put any cream at night. If you need to have rejuvenation for your face, put collagen creams or put retinol. If you need to have whitening to your skin, put glutathione or hydroquinone. That's everything. And if you have any question, you can see.
Thank you, Dr. Hala. Let's start with the first question. At which age should we start the rejuvenation procedures?
Okay. I want to tell you something. There is no exactly age. I mean, no 25 age you will start to make it, or 30 age you start. When you start to feel there is change of your skin, you should really come to start taking care, because as it's become forward, more laxity or more sagging of your skin, you will not have better result. So as you feel that your skin become to change, start to take care about your skin, either by procedure or by the daily routine. So it depends, maybe 25, maybe some patients until 30, depends on their lifestyle.
Second question. Does our skin become worse if we start injections than stopping it?
Okay, this is the important question. Most of our patients ask still, will they make Botox or fillers? If we stop using the injection, will become worse? No. As I told you, if you bring two sisters and one take care about herself a lot, another one didn't take, it doesn't mean that if the first one stop it, she will become worse. No. The collagen stimulating active, which happens with her, it will stay with her. So she will keep seeing her results. Always advise patient, don't be don't miss, like making 3 sessions per year and stop. Don't be very regular come to the clinic, you don't feel bored. Make 3 sessions per year, care, skincare, and then stop it, and you will have immediately or amazing results.
Thank you, doctor. Third question, which device is better, a fractional laser or carbon for peeling?
Okay, for me, if you want to have a very immediate result, but it will have a long downtime, you will use fractional laser. But as I told you, it's ablative laser, so you will see a long downtime and redness in your face. If you don't want to have a lot of pain and you can make multiple sessions like carbon, make carbon. It will be less aggressive to your skin and you will have results, but you need multiple sessions. So when the device is very aggressive, you see better results, but don't time. When the device is like soft device, you will not see amazing results immediately. You need multiple sessions, but there is no downtime.
What is the ideal amount of sunscreen that must be used to prevent photoaging?
It's amazing. You should put it as like this finger nodes, okay? And put it over your face, the first layer, and try to cover all the exposed area for your face, under your eyes, till the lips. You should put it, and if you don't put hijab, or put it for your face, and don't forget your hands. And as we told you, you should put it again after 2 hours. It's very important.
Last question, doctor. Botox works on dynamic wrinkles. How can any other procedure you mentioned delay or replace Botox?
Okay. Any procedure that we told it like microneedling, it will help for the collagen stimulation. So till this dynamic expression will become less aggressive to your face. You mean if you see the baby when speak or young children at 10 years old, they will not have very aggressive dynamic wrinkles. But as we old, when we speak, you see very aggressive dynamic wrinkles. By stimulating collagen by any device or anything we told you, you will have better results.
Thank you, Dr. Hala, for imparting your knowledge. Now, I would like to welcome our second speaker, Ms. Leah Maqsood, healthcare business consultant and founder of LMB Consultancy. Ms. Leah is a certified trainer from the American Society for Training and Development who will help you build professional relationships in the business medical field and train you to become a better version of yourself. She holds a BA in business marketing, an MBA in management and international affairs, and a DESS in management from HEC Montreal. Using her extensive experience and enthusiasm to share her knowledge as key elements to deliver her messages, you will receive motivating and promising training and advice you shall never forget. Welcome, Ms. Leah Maqsood. The platform is yours to present.
Thank you. Hello, everyone. Today, we are going to tackle a very important topic, which is the importance of the patient journey in the healthcare field. Nowadays, we still have a lot of people and patients who feel doctors, who fear injections, and who fear reactions. That's why it's our job to help them overcome this fear, especially in our customer service. Why? Because we are living in a very competitive market. There's a huge competition, and patients have different choices and options to use, and they are going to be choosing you again based on the unique experience that you will be providing. Who is mainly responsible for the patient journey? All workers in the medical practices, and mainly the healthcare workers, starting from the call center agents to the front desk officers, clinic managers and branch coordinators, doctor, nurses, all operational departments, a marketing department, quality department, helpers, and third parties such as suppliers. It's very important to have the teamwork spirit between all personnel and departments in order to be able to give the great image and deliver this exceptional service to our patients. The first impression really counts because it reflects the image of our practice and the perceptions of the service that we provide for our patients. The first impression starts with the phone etiquette. That's why at LMB Consultancy, we do focus a lot on investing on the team, especially on the phone etiquette. We train them how to deal effectively and professionally in a way to be able to convert all the calls into real leads and then one patient. Other than the phone etiquette, we focus a lot on the front desk because the front desk is the key. It's the first check-in point, like physical one with the patients. We should make sure that we are providing a 5-star service similar to a 5-star hotel. We should focus on every detail in all departments to ensure the patient satisfaction. Furthermore, we need as well to ensure that our team is friendly yet professional. They have always a positive attitude. They are helpful. They are attentive and they listen and care attentively to the patients. They have proper eye contact. They use their names whenever possible. And definitely they will be wearing this smile. The smile is very important. We should always be present for our patient. There's a saying that customers are kings and kings are never left unattended. We should be always available for them, know how to communicate properly with them, and be sure that we use the 3 V's of communication. The 3 V's of communication make us communicate effectively with our patients. And they are the visuals, the vocals, and the verbal. As you notice from the slides, the visual part take around 55%, which means that the body language, the facial expressions are very important and they are dominant while talking to others. And then we have the vocals, which is the tonality. We need to ensure that we are not monotone when we're addressing our patients. And the verbal takes around 7%, which means that mainly patients, whenever we address them, they focus on our body language and our tonality rather than the expression that we use. On another note, it's very important to put ourselves into the patient's shoes. We need to focus on every detail, starting, for example, from the reception area. We need to make sure that the magazines or the reading materials are up to date, they are clean. We need to be assured that you are going to get the ultimate experience from them and to retain them. This is very crucial. We need to show some emotions while dealing with the patients. We don't have to look commercial or to be robotic. That's why, in order to retain them, we need to show them these emotions while dealing with the patients. Quality is very crucial. Patients choose a certain practice or medical entity because they are assured that they will be receiving a top-notch quality service. The quality should be as well monitored in different sections, especially, for example, when it comes to time. We need to ensure that the patients are not waiting a lot of time when it comes to the consultation, to the file opening, to the appointments, to the payments. We need to make sure that we are reducing the waiting times and the delays for them. All our patients should be treated as VIP clients. We always hear this saying in the practice, this is a VIP client or this is a VVIP client. All our patients should be treated as VIP clients. We need to consider it as they were the first and the last patient to visit us, regardless their gender, their nationality, their ethnicity. We need to make sure we're offering this service to all of them in a very equitable way. And we definitely need to meet their expectations. And what are the patient's expectations? They need to get very good results. They need to be in a safe environment. They need to have a flexibility when it comes to their appointments. We need to reduce, they expect not to wait a lot in our reception area. If we don't meet these expectations, they are going to be disappointed. And this disappointment will lead to dissatisfaction. And this is really bad
Here I'm going, why? Because latest studies have shown that one happy patient will tell 3 people. However, one unhappy patient will tell 11 people. And now you do the calculation and you see that it will affect indirectly your business. Here I will give you like a funny example. Whenever you're throwing a birthday party and you want to prepare a cake for your friend and you order it and you get it like the one on the right, it will not meet your expectation at all. You will be talking badly about this baker shop. So it's very important to meet our patients' expectation to make sure that they are happy since their check-in until the check-out point. When we reach this point and when we know that they are satisfied, we will create a kind of bond with them. We will be sure that they will be loyal to us. They will be referring patients to us. And the word of mouth is one of the most powerful tools to get patients referral. And it's free, so you don't have to pay for it. Automatically, we will have an increase in our sales and in our profits. And this will definitely will keep us ahead of the competition. We have some of the behaviors that turn off the patients, and we need to be aware to avoid it, which is the apathy, the brush off, the snobby, the rule book, and using different standards. And definitely, if we don't avoid it, we will receive a lot of complaints. We should educate and train all the team in your medical practice to report the complaints. They should not be afraid to report the complaints because complaints are the best source of feedback. And it is common that 95% of our customers will become loyal when we resolve their complaints and we resolve it quickly. In that way, we will be able to turn them from upset into delightful patients. How can we get the complaints? Some patients, they don't like to face you face to face. They prefer to do it anonymously. How do we do that? Through surveys. At LMB, we do provide this kind of service, which is the survey. We otherwise provide a QR code to be set on the reception area, or we send a link through the email or through WhatsApp, like the platform that you think it's better for your patients. And at the end of the day, we will be projecting the answers through a dashboard with percentage, with a certain analysis and suggestions. Here, I'm gonna show you like an example for the waiting time. We always have to make sure that patients don't wait more than 15 minutes. This is the ideal time. Sometimes we have a delay with the patients, with the appointments, a critical situation with the doctor. It happens, but to be within the range of 15 and 30 minutes max. This is another example for the decision regarding their treatment plan. Another one regarding the cost. You will always notice complaints when it comes to cost. Always make sure that you never compromise the cost, your price when it comes to quality. This is important as well to bear in mind. Okay. Other than that, reviews. Reviews are very beneficial for your business, for your medical practices. Nowadays, we live in a digital world. Everyone will go online, will go over Google to check your reviews, to check the service, to check others' opinion. So always ask the patients. Never take no for granted. If you never ask, the answer is always no. So it's very important to ask our patients to give us some reviews, to ask them for some video testimonials as well. Video testimonials are powerful. We need to ask them to do it. It gives more credibility, more trust for our practice. So this is very important. What question do we ask in the video testimonials? We need to check what was the problem before they approached our center, how was it solved in our practice, and if they would recommend it to their friends and their family. They should mention it. As I said, it will give more credibility, more trust, and people and potential patients will definitely visit you. In order to conclude, you need to make sure that the checkout point is as much as strong as the check-in point. Why? Because it's the final interaction that will definitely resides in the memory of your patients. Even when your patient leaves, you need to follow up on them. You call the next day, or you send a message. You make sure everything was fine. Maybe you can send them a birthday message during on their birthday. So this is very important. Keep it in mind to finish strong. And there's a quote that I always like to use is that the smile is a powerful weapon. You can break ice with it. Smile is an international language. Make sure to use it, to smile, to wear it on your face whenever you talk and you address your patient. Thank you so much. And now I'm ready to have your questions.
Thank you, Ms. Leah. Let's start the question. So first question, what can we do to make sure we are providing a quality service?
Actually, we should have a quality department or assign someone to do the job. Like we can work, for example, on implementing the ISO 9001, which focus mainly on the quality management standards. And we can set the proper policy as a procedure for every department so we can track and assess the quality of work and service offered. So this is definitely would be an added value for the centers, and it will give the credibility and the trust, and it will attract more patients.
Thank you. So the second question, how can we measure customer satisfaction?
There's different ways to measure customer satisfaction. As I mentioned during my presentation, we should take their feedback mainly through email service. It can be in-house, or we can call them directly to ensure that they were satisfied and they enjoyed their experience in our practice.
And last question, how can we bring more leads to our practice or clinic?
We definitely should focus on the expertise and the skills of our team. They are the asset of each medical practice. We should have a strong digital presence, maybe work on some sort of collaboration, sponsorship. As I mentioned during the presentation, the most powerful referral system is the word of mouth. It's free of charge and you can definitely benefit from it. Any other questions?
Thank you, Ms. Leah, for sharing your thoughts regarding the importance of patient journey in the healthcare field. Now we are moving on to the 1-hour networking break. We would soon return with the fourth session at 2:20 Qatar time. See you.